Outcomes Research Seminar and the 12th in our COVID-19 research series. Today, we will be joined by Drs. Ann Parker and Tracy Vandersdal from Johns Hopkins University and Drs. Eva Schaefer and Bernard Iwigman from North Shore University Health System, who are joining us to present their research on post-acute sequelae of COVID-19. We will also be joined by Anthony Solomonides from the North Shore University Health System for our expert panel. Next slide, please. I'd like to start off and thank Dr. Iwigman, Director of the North Shore Outcomes Research Network, Program Directors for the Outcomes Research Network, North Shore Leadership. I'd also like to thank those in the front, working on the front lines and first responders during this pandemic, and everyone in the North Shore Leadership for supporting our seminar series. I'd like to go over the overall objectives of our series, and we're North Shore Outcomes Research Network, structured with key academic leadership, providing support to catalyze research across our North Shore system and the Institute for Translational Medicine academic communities across Chicagoland. The goals of the Outcomes Research Network are to enable uniform community access to care that is effective, efficient, and equitable, enrich the practice of medicine, and support key clinical, strategic, quality, and operational decision-making using data from our system, and as well as other investigators' work. The objectives of this seminar series are really to promote flourishing principal investigators. We want to disseminate the research of our research community, as well as resources to investigators and promote a culture of collaboration and team science. We also want to bridge researchers to their peer communities across Chicagoland, and we use the chat and the incubator hub for that purpose to begin those conversations. And we want to ultimately deliver outcomes research that demonstrates improved patient and population health outcomes for our communities. Next, Francesca. I'd like to introduce, most importantly, Francesca Carlock, who is the facilitator for this seminar series. And she is a research coordinator with the Outcomes Research Network. And my name is Sean David, and I'm the program director for translational science in the Outcomes Research Network. Next slide, and Francesca, over to you as you talk about the Zoom orientation.
Thank you, Dr. David, and hello, everyone. In today's webinar, all attendees will be muted with the exception of our panelists and speakers. However, there will be some opportunity for interaction. If you have any questions or comments at any point during the presentation or the Incubator Hub discussion, please submit your communication by using the chat function as noted by the blue arrow on the screen. If you are on a computer, you can access this icon by hovering your mouse over the bottom of your Zoom screen. Please give special attention to the audience of your message before you submit it. If you can see on the image to the right, you can choose to message either the panelists and speakers, this will include myself, or you can choose to message everyone on the webinar. Feel free to leave your questions and comments at any point during the presentation. If you're experiencing any technical difficulties, please let me know by messaging all panelists, and I will assist you the best that I can. I'm going to hand it back to Dr. David, who will now go over the agenda for today.
Thank you very much, Francesca. So after a brief introduction, we will be joined by our presenters. And first, we will have presentations from Dr. Park, Dr. Vandersdal, followed by Dr. Iwigman, and then Dr. Schaefer. During the presentation, we encourage you to put questions into the comments box as you go along. Feel free to do that at any point during the presentation, and we will use those in our Q&A session, which will occur at start at 3:45. And we'll have 10 minutes for questions and answers to ask the professors. Following that, we will have our Incubator Hub expert panel discussion, and that will run from 3:55 to 4:25, and then we can wrap up with some closing remarks and encourage evaluations and access to the video of this seminar through our YouTube channel. Next slide, please. Very good. So it is my honor to introduce our panel of speakers today. We have three presentations. The first will be from Dr. Ann Parker, who is Assistant Professor of Medicine and Assistant Professor of Physical Medicine Rehabilitation at Johns Hopkins University, as well as Dr. Tracy Vandersdal, who is Associate Professor of Psychiatry and Behavioral Sciences and Associate Professor of Neurology at Johns Hopkins University. That will be followed by a presentation from Dr. Bernard Ewigman, who is the Owen Kuhn Endowed Chair of Family Medicine, Director of Outcomes Research Network, North Shore University Health System, and he's a clinical professor in family medicine with the Pritzker School of Medicine at the University of Chicago. And then a final presentation from Dr. Eva Schaefer, who is the Vice Chair of Outpatient Specialty Quality and Operations for the Department of Medicine and Section Head of Allergy Immunology at North Shore. She's also a clinical assistant professor with the Pritzker School of Medicine at the University of Chicago. Next slide, please. And so without further ado, because we have quite a packed schedule today, it is my privilege to introduce Dr. Ann Parker and Dr. Tracy Vanderstal, who are visiting professors today from Johns Hopkins. So the show is yours.
Great. Thank you so much for that kind introduction. So I am really pleased to be here today to represent the Johns Hopkins Post-Acute COVID-19 team, or JH-PACT. And I co-direct the program alongside Dr. Alba Azola, who isn't here with us today. I have a primary appointment in pulmonary and critical care medicine. Dr. Azola is an assistant professor in physical medicine and rehabilitation. And I'm really pleased to have Dr. Vanderstal join us to talk specifically around her excellent work in cognitive outcomes in this patient population. Next slide. So before diving into our program specifically, I'd like to summarize what we do know so far about what we term post-acute sequelae of SARS-CoV-2, or PASC, also known as long COVID, also known as post-COVID condition. It goes by many names. So we understand that patients who are infected with SARS-CoV-2 develop symptoms that last on the order of weeks. Now, when these symptoms persist beyond about 8 weeks is when we start thinking specifically around PASC. We don't yet fully understand the mechanisms underlying PASC, and we're really just starting to understand what the trajectory might look like for some patients. Next slide. We know that acute infection with SARS-CoV-2 can impact multiple organ systems. And we're really understanding that the same is true for PASC. So we are seeing patients present with complex multifactorial symptoms that include things like fatigue and weakness. We can see patients develop cardiovascular complications. Our patients tend to have an increase in anxiety and mood symptoms, even post-traumatic stress disorder or PTSD symptoms. And these can be associated overall with an increase in healthcare utilization and even an increased risk of death. And this is true for patients who have mild initial infection and never require hospitalization, as well as those who are severely ill with COVID-19 and require care in the ICU. On the order of 10 to 30% of patients will have persistent symptoms after their initial COVID illness. And so when we start thinking about raw numbers, this has huge implications for our healthcare systems. Next slide. So again, when we talk about trajectory, we have to remember that this pandemic has evolved quickly. And when we're thinking about long-term symptoms that fall under the PASC or long COVID umbrella, we're really just starting to scratch the surface and understanding what symptoms might look like 6 months or a year down the road. And so much of the data that we have is really coming from our colleagues in Italy and China, who were temporally ahead of us in terms of the pandemic. So I'll specifically summarize what we know from some of the larger studies that have come out of China. So this is a study that looked at about 1,700 patients at 6 months after their initial COVID illness. This was primarily a study of patients who required hospitalization, but not necessarily in the ICU, where only 10 patients in this study required invasive mechanical ventilation, or ECMO. You can see that 3/4 of these patients had at least one persistent symptom at 6 months. Most commonly, this was fatigue or muscle weakness. We see shortness of breath occurring in about 1/4 of patients. Interestingly, the most common abnormality in pulmonary function tests is a decrease in oxygen diffusing capacity, which is in line with what we understood from patients who had acute respiratory distress syndrome, or ARDS, from other causes even before COVID. We see that about 1/4 of patients report some symptoms of anxiety or depression. In this particular study, only about 5% had more than slight mood symptoms. Patients were performing at 88% of predicted on a 6-minute walk test, which is below normal and below what we would expect. Interestingly, when they did a lower extremity ultrasound on about 400 patients, they did not find any new venous thrombosis. And I think this is an important thing. We talk a lot about the propensity for clotting in patients who are acutely ill with COVID-19. And we're not seeing, either anecdotally in my own experience or borne out in the literature, a tendency to form new clot many months after an acute COVID illness. Now, in this study, a greater proportion of patients who required more respiratory support, so high flow nasal cannula or more, reported more shortness of breath, decreased mobility, and anxiety and depression symptoms. Next slide. So of those 1,700 patients, they were able to follow about 1,200 patients out another 6 months to 1 year after their initial COVID illness. And again, this is primarily a study of hospitalized non-ICU patients. So at a year after their initial illness, half of these patients still had at least one persistent symptom, again, most commonly fatigue. Shortness of breath occurred in about a third of patients. And again, the most common PFT abnormality was a decrease in diffusing capacity of oxygen. But I do point out here that there was a decrease in the proportion of patients who met criteria for restrictive lung disease from 6 months to 12 months. Again, about a quarter of patients reported anxiety and depression symptoms, and there was no change in 6-minute walk test as a measure of physical function from that 6-month to 12-month period. In this study, they compared patients with matched controls who did not have COVID-19, and a greater proportion of those with COVID-19 had shortness of breath, decreased mobility, mood symptoms, and pain. Next slide. So I think it's important to point out that when we conceived of our program back in the spring of 2020, of course, at that point in time, this concept of long COVID or persistent symptoms was really new. And so we didn't have the benefit of these studies that I've just reviewed with you. What we did know is that patients who require care in an ICU can develop impairments in mental health, cognition, and physical function, collectively termed post-intensive care syndrome, or PICS. And this is from literature dating back decades, well before COVID. We also know that patients that have these symptoms can have symptoms that last for months to years after their initial experience in the ICU, and that these can be associated with worse quality of life. And so when we were conceiving of our program, we really built our framework around this concept of PICS. Again, understanding that at least a subset of our patients would require care in an ICU and be at risk for persistent impairments. Next slide. This is a figure taken from a protocol paper evaluating how unmet needs after hospitalization for acute respiratory failure, again, not necessarily from COVID, but from any cause, are associated with subsequent readmissions and mortality. And so again, when we were conceiving of our program, we tried to think about what a patient who has complex multifactorial symptoms might need in order to improve outcomes across a wide array of symptoms. And so we thought carefully about how we could incorporate each of these factors into our program to be able to address patients' needs, again, from this population of patients who can present with a number of different types of symptoms and combinations of symptoms. Next slide. So again, our program was established April 7th, 2020, making it one of the earliest in the country. And again, we built our framework around this concept of post-intensive care syndrome. We are a multidisciplinary program that is a partnership between pulmonary and critical care medicine and physical medicine and rehabilitation. We started initially as an entirely telemedicine program, and we existed as such for many months before introducing an in-person component as well. And we now have a hybrid model that allows us to meet patients where they are. We have two components to our program. I've spoken a lot about meeting the needs of our post-ICU population. We also see patients who have mild to moderate initial illness. And so these are patients who have ongoing pulmonary and/or rehabilitation needs after their initial illness. Next slide. Our overall model is a core team of pulmonary and critical care medicine, physical medicine and rehabilitation, and our home care program who have provided essential care to our patients in their homes throughout the pandemic. And then we have established targeted referrals to other subspecialties depending on patients' needs. And we've also coordinated very closely with our primary care providers as our model serves as a transition from that post-hospital setting back into the primary care atmosphere. Next slide. So we have now seen about 850 unique patients. On the order of 50 to 70% have been admitted to the ICU. And so initially, a greater proportion of our patients were coming out of the intensive care units. But as our program has progressed, we have seen more and more patients who had initial mild severity of illness. Our patients are young. The average age is about 54 years. About half of them are male. About a third identify as Black or African American, a third as Hispanic or Latino, and about a fifth require interpreter services. And we also see a number of patients who are underinsured or uninsured. And so we have a population with high needs and often who are sort of initially establishing care, have not been in contact with primary care providers. And so there's a lot of opportunity to engage them. Next slide. So I'm happy now to hand the baton to Dr. Vandersdal, who's done some outstanding work in understanding cognitive outcomes in our patient population.
Thank you, Anne. So thank you for having me. I am a neuropsychologist here in the Department of Psychiatry. And early on in the pandemic, as the PACT clinic was getting developed, we appreciated that there was a need to assess for cognitive and mental health outcomes in this patient population. And so we designed a telephone-based cognitive test battery that is administered to patients around the time of their first follow-up PACT visit. So on average, that's around 4 months after their acute illness. We chose a telephone-based battery because we were still at the time in the midst of the pandemic. Most of all of the PACT clinic at that time was virtual and not in person. And video-based cognitive testing, while effective, really would limit our ability to access some of our most vulnerable patients. So we used a telephone-based battery that's based off of some other large epidemiologic studies. And we assessed learning and memory, processing speed, executive functioning, attention, working memory, and verbal fluency in our patients. And we defined cognitive impairment relative to performance from an existing normative sample, adjusted for age. And so mild or moderate impairments were those scores that fell below the 7th percentile, and severe impairments were those scores that fell below the 2nd percentile. Next slide, please. We also wanted to make sure that we were tapping into symptoms of depression, anxiety, post-traumatic stress, and functional decline. Next slide. And so I won't spend much time on this since the data that I'm going to be showing you are for our first 82 English-speaking PACT patients. We also administer the same battery in Spanish, and I'm not going to be presenting our Spanish language data today. All of our demographic characteristics are consistent with the larger PACT clinic in that we're majority minority, the average patient's in their mid-50s, and our patients are well-educated and have solidly average estimated IQ. So just a really nice sort of snapshot of the general population demographically in terms of the patients that we're seeing. Next slide, please. And so these are our age-adjusted standard scores. So lower scores are reflecting poorer cognitive performance. And like Dr. Parker mentioned, we are looking at our patients in two ways, those that required ICU care and those who did not require care in the ICU. Either were in the hospital but weren't in the ICU, or they remained ambulatory. And what you can see really clearly is that most of these cognitive test performances are below expectation relative to normative standards, particularly as it pertains to verbal fluency, processing speed, learning, and memory. And we see this clear stair step whereby our ICU patients are showing greater deficits than those that did not require that intensity of care. Next slide, please. And this is another way of showing these data, demonstrating that 2/3 of our patients are showing abnormalities in at least one of these 8 cognitive domains or abilities. We're seeing roughly the same proportion of patients in each clinic producing at least one abnormal score, And it's certainly a greater rate of abnormality than we would expect for a test battery of this length. Next slide, please. And when we look at psychiatric symptoms, we're seeing fairly high rates of depressive symptoms, symptoms of anxiety. A quarter of our patients who were in the ICU are showing persistent symptoms of PTSD 4 months after their acute illness. And our measure of functional decline really taps into changes in everyday functioning that's due to cognitive changes and changes in mood. So what we're seeing is that these cognitive difficulties are elevated in this population. They're accompanied by affective distress, and it's translating into difficulty carrying out activities of daily living. Next slide, please. And so that's just a really quick recap. And I would just note that this is 4 months after acute illness. So many of our patients are trying to get back to work, and they're running into difficulties sort of fulfilling those life roles that they had been engaging in prior to their illness. Next slide. So in terms of symptom management, I really think that our data are pointing to the need for multidisciplinary care teams so that we can, one, identify the types of difficulties that our patients are experiencing. I should say that our cognitive impairments and our emotional difficulties were not correlated with one another. So just because a patient's experiencing depressive symptoms or anxiety symptoms does not necessarily mean that they're performing poorly from a cognitive standpoint and vice versa. So we really need to be measuring in order to know what our patients need. We need to have providers available to provide interventions. Right now, we have very little by way of empirically supported interventions specifically for post-COVID or PASC, but we can easily fall back on empirically supported interventions that have been designed based on other patient and medical populations. And those seem to be working really well, but it remains, the data really are sort of still being collected. And I think we'll have more of that as time moves on. So next slide. Dr. Parker and I both have a few acknowledgements. We definitely want to thank all of our team members. Next slide, please. And I think our very last slide, if you could go one more, is our clinic details. Thank you all.
Thank you very much, Dr. Parker, Dr. Vanderstal, for a really brilliant and I learned a lot presentation. So we'll have time to return to Q&A at the end, but next up, if we could go to the next slide deck. Next up, I'd like to introduce Dr. Bernard Iwigun, who will be presenting his work on post-acute sequelae of COVID-19, preliminary studies, and work from our enterprise data warehouse. So Dr. Iwigun, you have the floor.
Thank you, Sean. First thing I need to say is that I'm presenting on behalf of a large group of people. There's been a lot of people involved in this, clinicians as well as investigators. I also want to thank Dr. Parker for that nice intro and overview, and Dr. Vanderstal for those fascinating findings with respect to neurocognitive mental health outcomes of their patients in that cohort. So what I'm going to present are some preliminary studies that we launched pretty early in the process as well. A survey and a query of our enterprise level data warehouse. I'm going to just present a few key findings. We have a lot of findings, but I think the purpose of this talk is really to provide kind of a segue between the presentation from our colleagues at Hopkins and what Dr. Schaefer is going to talk about in terms of our clinical and training responses. And again, these studies were primarily designed to give us some handle on what we were dealing with. And then I want to talk a little bit about the future research needs and opportunities, as that will be one of the primary topics of our discussion in the incubator hub on the panel at the end. Next slide, please. So as I said, two sources of data. One was a provider survey. The other was a query of the enterprise level data warehouse. Next slide. I'm not going to go into detail at all on the methods, other than that our intention was to survey all of the providers in the current integrated system North Shore, Swedish, and Northwest community. We were able, including physicians, advanced practice providers, and psychologists, we were able to get a total of 462 responses, which is about 10%. There were about 4,600 of these providers in our group. We had strong support from all of our chief medical officers and clinical chairs. And again, I won't go into the details other than we did item development, cognitive pretesting, pilot testing, used multiple platforms, and had multiple requests. The second one was the EDW query using the North Shore Legacy enterprise level data warehouse. And for those of you who are not part of North Shore, the quote North Shore Legacy has 4 hospitals and about 1,000 employed physicians and probably a couple thousand affiliated physicians. Swedish Northwest community have joined us, and but we don't have all of our Epic platforms integrated. At any rate, what we did was look at the overall numbers from the beginning March 1st, 2020 up until November 8th, all positive PCR tests and all encounters in which there was a diagnosis or a chief complaint that had, at least at that time, been associated with post-acute sequelae of SARS or long COVID. So you'll see some findings based on the survey, some findings based on that overall number. And then we also carved out a longitudinal cohort of patients who had a positive test in the first 6 months, for which we then had 12 months of follow-up data. Now, these were patients who had primary care providers and had been seen within the last 24 months. And so it was more of a continuity population, and we thought we might get a little better sense of the natural history of encounters with that population. Next slide. Response rates were quite variable. I won't go through the details other than that we had about a 15% overall response rate from the North Shore Medical Group. But within the specialties that are seeing large numbers of these patients, we had a pretty good response rate of 45%. And those are listed here. I won't go through them. They're not surprising. I think everyone knows who's seen the large majority of these patients. We had 49,000 positive COVID tests during PCR COVID tests during this period, and 16,229 post-acute visits just in the legacy North Shore Medical Group providers. And that doesn't include the affiliates with North Shore Legacy, Swedish, or Northwest Community. And of course, we're partnering or merging with Edward Elmhurst. And so we'll soon be one of the largest integrated systems in the country. We identified 991 long COVID patients for the longitudinal cohort. And again, we have 12 months of follow-up there. Next slide. Okay, so I'm just going to show a few of the findings. I think these were helpful for us internally. They are reasonably consistent with the literature. There's a lot of limitations to these studies, but like all studies, constitutional, quality of life, functionality, and disability symptoms were quite common, as well as either organ-specific or specialty-specific symptoms and conditions. Again, this virus affects almost every organ system, and almost every provider has some contact and interaction in the post-acute period. Next slide. This gives you a sense of the referrals in the initial part of the pandemic with pulmonary and critical care, neurology, cardiology, otolaryngology, rehab, primary care, allergy and immunology, psychology, gastroenterology, and psychiatry representing the top 10. Again, not surprising, but it was helpful to us in terms of thinking about how to structure our clinical operations and services, as well as our training that Dr. Schaefer has led and has been a key part of this preliminary study as well, and will be presenting following my presentation. Next slide. This just gives you a sense of, among those 49,000 tests, we did a lot of tests for other systems because our pathology department got up to speed pretty quickly. But we did have 6,000 patients that were seen in our medical group and had about 12,000 encounters. The main point of the slide here, and you may not be able to see all of the font, but essentially the yellow and the gray is primary care, immediate care, emergency medicine, and that of course has been over half of the encounters. And then you'll see cardiology, neurology, endocrine, peds, and the other specialties that you're aware of. I think the key point here is that everybody gets involved in this problem. Almost every specialty is represented here. Next slide. This gives you a little sense of our attempt to estimate the type of conditions or problems based on the diagnoses and chief complaints that we were able to pull out. The blue bar shows patients who had a PASC associated or a long COVID reported diagnosis or symptom who had also had a pre-existing condition. So folks with hypertension, diabetes, although we know that many of these conditions have been greatly exacerbated, we don't know whether that's due to lack of medical care, whether that's some pathophysiologic mechanism. I know my neurologist colleagues have told me about patients with well-controlled headaches that have gotten much worse and require a lot of new management. Now, in the orange, we see new diagnoses and symptoms that did not exist, or chief complaints that did not exist before the pandemic. And we have, we go back multiple years in our medical records with this cohort. And some of these have 1, 2, there's some with 4 or 5 new conditions that clearly have very persistent and disabling conditions. Next slide. This was perhaps one of the more interesting slides to us in terms of looking at encounters over about a 1-year period for this cohort of 989 patients. The blue bars here represent a definition of lower likelihood of persistent PASC, and the orange bars represent a higher likelihood of persistent PASC. And I won't go into how we define that. But what I want to point out is that over about the first 6 months, we see a decline. And then in the second 6 months, it gets to be fairly steady. Now, these are encounters. And so it suggests that at least in our system, it takes about 6 months for the encounters to level out. And it looks like they just continue after that. Next slide. Okay, I said that this was primarily for the purpose of planning clinical operations and training. I've already mentioned some of the findings here in the first 2 points, 3 points really. But I think the key here is for the purpose of planning for healthcare services and training folks is that these encounters are going to continue to grow over time in our system. We have that the 12-month follow-up is only for the first 6 months. And of course, we had multiple surges since that time. The Center for Post-Covet Recovery at North Shore, which Dr. Schaefer is going to introduce us to, it really is on track, I think, to meeting the training needs, providing guidelines, diagnostic algorithms, EMR tools. And we had a number of items in our survey to address those. And I will just say that she and others who have led this have done a great job of having an integrated system approach that I think this data and our experience shows is well suited to the diversity of symptoms, multiple system involvement, and the wide spectrum of specialties involved. There's a lot more to learn, a lot more to know. I think we will clearly be, in my opinion, developing specialty-based COVID services as people begin to focus on this in various specialties, and perhaps a multi-specialty such as the folks at Hopkins have done. Next slide. So I want to just turn my attention to the limitations. And if we could just go to the next slide. I started on this slide, but I realized that it would take another 20 minutes to describe the limitations. So I'm just going to acknowledge folks. There's many people to acknowledge, but I have to acknowledge Dr. Schaefer, who's really kind of organized a lot of the clinical content experts. Next slide. And then I would also acknowledge Jana Wickwicki and Jackie Pruitt. If we can go to the next slide. Yeah, there it is, who really did much of the heavy lifting for the survey and the provider survey, as well as the EDW query. So I just have 3 more slides, and it really is, these are slides that are kind of designed to prompt our discussion after Dr. Schaefer's presentation. This is a huge problem. I don't need to say that, but to put some numbers on it, we're now at close to, or maybe a little over by now, 50 million COVID-19 infections in the United States. You've seen that there's quite a range of estimates of long COVID. Depends on the population, risk factors, depends on how you define and measure this, but I just used a range of 10 to 50%, which would mean there's 5 to 25 million patients potentially experiencing long COVID or will experience long COVID in the United States. Just at North Shore, almost 50,000 positive tests, which translates into 5 to 25,000 of these patients. And of course, a lot of the care involves figuring out whether this condition is even related to COVID or some other etiology. And what I want to say is that despite a real avalanche of research, which has been, I think, fantastic, we do lack basic biological and epidemiologic knowledge still. And there's a lot of reasons for that. One of which is that long COVID or PASC is not a single disease or syndrome. That was pointed out by our colleagues at Hopkins. Post-ICU syndrome is certainly a part of it, but there's chronic fatigue, autoimmune responses, persistent viral infections, pulmonary, neurologic, cardiac, psychiatric, and other diseases and syndromes. So we're really not studying one phenomenon. There's many phenomena to study. Next slide. And the challenge is that at this point in time, while people are using working definitions, which is useful at this stage of research, it's very poorly defined. These are heterogeneous conditions of uncertain prevalence, incidence, etiology, prognosis, treatment, and rehabilitation. I do want to say that I think that our historical clinical knowledge is proving to be extremely useful. We're beginning, I think, to feel like we're doing good things for these patients, but we do need some more definitive evidence to really document that. We don't know enough about it. There's inconsistent definitions and diagnostic criteria, and tremendous opportunity for secondary data analysis with EMR data, but we have, inconsistent coding definitions that really make that a challenge. Next slide. So let me just conclude with opportunities. The NIH has committed $1.15 billion in funding to this problem, which is more than many federal research agencies. And the CDC, World Health Organization, many universities, health systems, as well as clinicians, investigators, advocates, and patients have become deeply engaged in addressing this problem. And I think that's very, very encouraging. The necessary research is underway, including basic biological and pathophysiologic studies, robust prospective cohort studies, which are desperately needed really to have a more rigorous epidemiologic understanding. There's patient engaged and community engaged research, as well as additional rigorous epidemiologic and applied clinical research. So I want to end with a question, and that is, what can North Shore contribute? And once we're fully engaged with Epic across our systems, we have a tremendously huge population to contribute to many aspects of the research that's going on around the country. And I just want to leave that with the question, because we'll come back to that as we enter the panel discussion. So with that, next slide, and I'm very pleased to turn this over to my colleague, Dr. Eva Schaefer.
Thank you, Dr. Yogman. Next slide, please.
Yeah, there you go. Okay, you're on, Dr. Schaefer. I don't want to hold things up, but for a really impressive work by you and your team. And next up is Dr. Schaefer.
Thanks. Next slide, please. So today I'm going to provide a brief overview of some of our clinical efforts here at North Shore. Dr. Yogman did an excellent job of going over our Epic data warehouse query, as well as the clinician survey that was sent out across the system. So alongside of that, we also established a multidisciplinary clinical team among the various subspecialties of the multi-organ system effects of COVID to be involved in this process. What we realized was one of our primary goals with this effort was going to need to be broad education across the system of post-COVID and post-COVID care, and also an understanding that things may change over time as more data becomes available. And then as we started the educational efforts with our Post-COVID Care and Recovery Conference series, we also worked to develop a centralized intake and triage process to guide specialty referrals. That was based primarily on whether a patient was hospitalized or not hospitalized with COVID. There was a little bit of a different algorithm, which I will go over later in this presentation. Next slide, please. This is a list of many of the specialties involved in our case conference series. And you can tell from this slide that we did involve just about every specialty that sees patients here across our system. Next slide, please. At every conference, we did review the definitions for acute, ongoing, and post-COVID symptoms, and really focused on those post-COVID-19 symptoms. So symptoms that were present for more than 12 weeks and not attributable to an alternative diagnosis. As has already been discussed, there is data showing that post-COVID can increase symptoms of some underlying chronic conditions that are not necessarily COVID. Next slide, please. As more information became available in the care of these post-COVID patients, especially for non-hospitalized patients, a lot of their care has been housed in primary care. And so with each conference series and with educational efforts across the system, we kept relevant literature that was coming out in the care of these patients. Next slide, please. This is a slide that you've seen previously from our colleagues at Hopkins, going over the acute infection of SARS-CoV-2 with lingering symptoms that can last for many weeks. When I looked at this chart for the first time, I was reminded of what a colleague of mine had said early in the pandemic. COVID infection is very similar to influenza infection, giving rise to mono-like symptoms in terms of a prolonged recovery. And what I've tried to keep in mind as an immunologist over the last year and a half is that we see post-viral symptoms with many, many other viruses, and we do not yet know the true natural history of COVID infection and COVID recovery. And we do, as we've seen more information, this is in line with many other viral illnesses in terms of some patients are taking quite some time to recover. Next slide, please. So this is a list of some of the conferences that we have put on. So our case conference series, we did have a case with each topic, and we presented these conferences at Friday morning at 7 a.m. Across the system. And all clinicians across the system and administrators were invited to attend these conferences. And this is a list of some of the topics that we have covered over the last year or so. Next slide, please. So with our educational documents, training documents, templates, and also conferences, we've posted all of these to our North Shore COVID-19 website so that they can be referenced quickly by our clinicians. Next slide, please. Our multidisciplinary team also worked together to develop handouts for some of our patients for rehabilitation services. And then our rehab and integrative medicine services have also worked together to provide programs for many of these patients recovering from COVID. Next slide, please. As has previously been mentioned, many of these patients need recovery therapy services. So we had our rehab services specifically not only learn how to care for these patients, but reach out to these patients and be available for scheduling, as well as our integrative medicine services have really done an outstanding job, not only in terms of providing services for these patients, but classes and support groups as well. Next slide, please. And then for some of our patients that medically didn't qualify for rehab services, there was a COVID-19 or is a COVID-19 strength and endurance class that is hosted by our rehab services. Next slide, please. Our specialists also created, this is just an example of several of the smart phrases within our EPIC system for our primary care physicians and other clinicians to use regarding frequent post-COVID symptoms for patient handouts. Next slide, please. As we worked on the educational portion of post-COVID care and recovery, we did realize that we needed to identify a medical director for past care. We elected to identify a medical director within primary care, and that medical director, Dr. Michael Glickman, has been running the past care for our primary care providers for approximately the last 2 months. And with that, he's consolidated various tools and resources for our physicians to use. Next slide, please. These resources include past care intake and history, going over various organ systems, including mental health as well, since that is so common in these post-COVID patients. Next slide, please. And also defining the severity of their illness and what treatments were provided. Next slide, please. And then in our clinical, these are also tools that are being used by our primary care physicians and accessible for post-COVID evaluations. Next slide, please. This is an algorithm that we're using for our clinical intake, for our triage intake for hospitalized patients. And the time in which these patients will be evaluated really depends on the acuteness of their disease, or severity of their disease rather. Next slide, please. And this is the pathway that we're using for patients that were not hospitalized, really relying on our primary care network of clinicians to first evaluate these patients, as many of them do resolve a lot of their symptoms over time. And with that, I think I'm going to pass off for our panel discussion. Next slide, please.
Thank you very much, Dr. Schaefer, for really impressive work. I'm going to hand this over to Francesca to field the questions and answers. And please, all participants, submit your questions in the chat. I believe there's at least one question, Francesca.
Yes, thank you so much, everyone. So as Sean said, we'll take a few questions from our listeners. As stated earlier, please input any questions in the chat box, and we'll address that to the panelists and speakers so the attendees can be involved. If all questions are not addressed, please feel free to contact our presenters at their emails shown on the screen. Let's start off with the first question for the speakers. Were the numbers reported from China, 78% of COVID patients with at least one symptom at 6 months, were they similar to what you have observed at Hopkins and North Shore?
I can speak to our experience at Johns Hopkins. So I think what's a little bit challenging is that there certainly is some degree of selection bias when we're talking about post-COVID clinics, right? So patients who are being referred, who are actually showing up to clinic, may be inherently different from other patients who have COVID who are not ending up in our post-COVID clinics. And so I think that speaks to the importance of these larger prospective cohort studies that are rigorously conducted and really trying to include patients who, are not necessarily only the ones who are presenting to our post-COVID clinics. So, I think I pointed out that we do have data from China, data from Italy, and I think we're really just starting to see some of those larger studies evolving with the NIH initiatives and the Recover initiative, for example, in the United States. So hard to say. We certainly see a number of patients with persistent symptoms, but understanding the prevalence and incidence really depends on these cohort studies.
So this is Bernadette Wigman. I totally agree with Dr. Parker that there's a significant selection bias issue with respect to the populations. In addition to the fact that the populations may be different, some ICU patients, others, mildly symptomatic ambulatory patients. There are also issues with the length of follow-up, with the actual outcomes that are measured, and the method by which they're measured. So, with some studies, you'll find social media reporting with, self-reported diagnosis and symptoms, and you get a very different number than you might with more rigorous clinical documentation, laboratory studies, imaging, pulmonary functions, that sort of thing. So I think when you see those numbers about persistent PASC or persistent long COVID, you have to pay attention to the population, the measures, the method of measurement, and the length of follow-up in order to know exactly what that means. And as we've mentioned, this is not one condition. So these numbers that we're quoting now, I believe, are very rough and very difficult to compare.
Thank you, Dr. Wigman and Dr. Parker. I think we have time for one, maybe two more questions. A question from Sarah Polonsky. Are you tracking what happens with patients with long COVID who receive vaccine either before and after their illness, and what are you seeing?
So this is Bernard. Short answer is no. And I think it's a great question, though. And really what I hope we can get to here in this panel discussion is what should we be doing at North Shore? What else do we need to know based on our own data that we can't surmise from the literature? And what can we contribute to generalizable knowledge? The opportunities are nearly endless with respect to what could be studied. And the whole vaccine question is obviously a really, really important one. We are doing some studies looking at immune response among rheumatology patients and cancer patients who may be immunocompromised or may not have a good immune response. But I think one of the things we need to decide is, given the strengths and the limitations of North Shore as a system, where should we put our emphasis on what kind of research?
Thank you, Dr. Ewickman. Oh, go ahead. Pardon me.
I'm so sorry. No. So we have not been systematically tracking response or infection rates or things like that after a vaccination in our patient population. I can speak to, there was a relatively recent Lancet infectious disease paper that did try to tease out what, how vaccination might affect subsequent tendency to develop persistent symptoms. So in that relatively large study, I think what they were able to demonstrate is that patients who were vaccinated, I think both after a first and second dose, were less likely, of course, to be hospitalized, less likely to get COVID, right? And so if less likely to get COVID, less likely to develop persistent symptoms. Patients who are vaccinated were also less likely to have, I think they looked at 5 or more symptoms. So they tended to have fewer symptoms with their initial COVID infection. And they were also less likely to have persistent symptoms beyond 28 days. And so I think that starts to hint at perhaps the effect of vaccination on the tendency to develop PASC or persistent symptoms. It certainly isn't the end all be all, but it's one of the larger studies that I've seen so far. And I can put the link in the chat.
Thank you, Dr. Parker. I apologize for interjecting, but that is all the time we have for questions. Please feel free to insert anything additional into the chat box for our presenters to review. I will now hand it over to Dr. David, who will introduce our expert panelists for the Incubator Hub panel discussion.
Thank you very much, Francesca. And again, thank you very much to all of the speakers for really brilliant presentations and very provocative findings. This clearly is a big problem, much bigger problem than I was aware of going into this seminar. So I would like to now reintroduce our speakers, but also introduce for our next segment, Dr. Anthony Solomonides, who is the Program Director for Outcomes Research and Biomedical Informatics Research. And he will be joining our presenters to engage in Incubator Hub panelist discussion, providing some additional insights on the implications of the work for biomedical informatics research and translational science. And I'd also like to reintroduce again Dr. Ann Parker and Dr. Tracy Demerstall from Johns Hopkins, Dr. Bernard Ewickman, and Eva Schaefer from North Shore as we go into our expert panel discussion. Next slide, please. So we have a panel representing 2 institutions and several different levels of observation addressing PASC. And so this is a real opportunity to really help us think about how we can prepare for the future going forward. And so we have 4 discussion questions, and I'd like to open these up to all the speakers and panelists. The first one is, what are the most pressing clinical problems and knowledge gaps in PASC that you'd like to see addressed? Feel free, any of you to jump in first.
I'll comment on this to start. I think in terms of knowledge gaps, this is a new virus, and the information that we have is really the information that we have starting back in January of 2020. And so what we need to realize is, I think we're not going to truly know the true effects of COVID and long COVID and the resolution and what we need for many of these patients for many years to come. So we're doing the best that we can with the data that we have. So I think that's the biggest in terms of knowledge gap. It would be really nice to have 20, 30 years of data on these patients and do asymptomatic infections really have no symptoms long-term, or, infants born to moms who had COVID at the time of delivery, do they really have no consequences long-term? So I think that is one of the biggest frustrations. And at the same time, I think it's causing some friction in terms of taking care of our patients, because our patients really like us to have the answers for them, and we don't. So that has been very pressing. In terms of what we need to, follow clinically, I'm very interested in terms of like the pulmonary complications for our patients. So taking care of some of these patients inpatient, seeing the extensive nature of their pneumonias, and the amount of oxygen that was required for many patients that were taken care of on the floor. So what are the long-term consequences pulmonary wise? And I think we're gonna start seeing some data on that, because we're gonna have probably some 1 year or 18-month follow-up coming soon. But it's a big question for me. Are we creating a large population of people that are going to have chronic lung disease for years to come?
Yeah,
Thank you very much. Yes.
Yeah, I very much agree with Dr. Schaefer, in that it's hard for our patients who have had symptoms for many months now. But when we start talking about long-term outcomes, we're really thinking at 6 months, at least a year. And we're just barely there in the pandemic, right? In terms of seeing these patients at a year after their initial illness. So I think the gaps are huge, right? Like we haven't fully defined PASC. We haven't fully defined long COVID. I think we're picturing overlapping Venn diagrams for patients who have PASC and patients who have, what I talked about before in terms of post-intensive care syndrome, and patients who are in the ICU. And, there's also overlap with patients with chronic fatigue and POTS. And, I don't think these things are all synonymous, but there certainly are overlapping features. So understanding prevalence, incidence, risk factors. I think this is a huge opportunity to understand underlying mechanisms, not even just for COVID, but also other similar viral conditions. There's a lot of missed opportunity with earlier coronavirus epidemics, and I think we don't have a lot of great data following patients from MERS or SARS-CoV-1 and understanding their persistent complications. Like, how great would that be to have that now, to be able to lean on those data? And so, and I think the other thing that's really important is carefully considering control groups in both our prospective cohort studies and our randomized trials of interventions moving forward, but understanding, how patients with COVID might compare to patients who have flu or other viral illnesses, comparing patients who are in the ICU with non-COVID viral infections or for other causes. So I think all of those things are really important.
And those are great points. Sorry, Tony.
Go ahead,
I just want to comment. The other gap is how much we may be seeing of worsening of other chronic illnesses that happen subsequent to COVID. Because many of these patients, especially in the hospitalized population, were not healthy to begin with. And so how much of this is really worsening of underlying chronic disease, I think needs to be teased out as well.
So one bright spot is the collection of data that we have been doing. Several projects have been amassing enormous amounts of data. I'm involved in the National COVID Cohort Collaborative. I was just reminding myself of the statistics. 9.2 million individual patients, 3.25 million positive COVID cases. Now, I know this doesn't make up for, the lack of longitudinal data, but there will be substantial volumes of data for us to learn from. I'm sorry, I'm getting a message that my camera is off. In fact, my camera is on, but I have an unstable connection.
So this is, I'm sorry, you done, Tony?
Yes, go ahead. Yeah.
Okay, thanks. So yeah, I don't know what's happening with my video either, but hopefully you can hear me. I totally agree with the comments that have already been made, especially the long-term consequences. I mean, these are folks that are, really going to be disabled or have chronic problems that are life-changing. One thing I would add from a primary care perspective, since we tend to see a lot of these patients, and is really what the prognosis is, because a lot of what we do in primary care is really try to assess what's the likelihood that this is going to be serious or going to continue. Do we need to, burden our subspecialist colleagues with this patient or that patient? And it's really kind of guesswork at this point and kind of clinical judgment. So I think having some more specific knowledge about how to characterize these various conditions and syndromes, what the risk factors are, and how to assess when is there really going to be value in referring to a pulmonologist or a neurologist or other specialists, rather than just saying, oh, you've had COVID, go see somebody else. So there's a lot of knowledge that's necessary for primary care physicians to do their job of taking care of most people most of the time, but being sure to get the patients who are going to benefit or need that kind of diagnostic expertise from our subspecialist colleagues.
Yeah, thank you. I agree with everything everyone said. One thing that struck me was the very high rate of cognitive impairment and referrals to neurologists. And how much do we know about the effects in the central nervous system of COVID-19? And if we knew more, could we understand more about anxiety and depression? And could that also help us advance dealing with those, even in non-COVID infected people, with pandemics that are occurring in parallel with this pandemic? So it's a lot of translational work to be done. At the same time, people are doing the dissemination, implementation science while we're still learning about the basic science. Seems to be a big gap. So if we could move on to the next discussion question. So then, given all of these gaps and the challenges that we face, and this is a big problem. This is not an unusual situation to have prolonged symptoms. How do we align our clinical priorities taking this on with external scientific funding priorities going forward? Dr. Liebman referred to a large NIH investment in this area, but how can we really align what we're doing in our health systems with where we need to go seeking external funding? Thoughts to any of you?
Aligning clinical priorities with research is a hard problem. There's no question of that. The NIH has provided an enormous amount of funding, and it does seem to be somewhat biased towards solutions rather than just research results. So I'm somewhat optimistic on that front. However, it has to be said that the process by which they're delivering those funds has been unusual, to say the least, and it may not be so easy to follow through.
Could you say more what you mean by that, Tony?
Well,
the unusual way in which they delivered funds?
They've used the other transaction authority on several fronts recently, and this is it's not the way that we're familiar. The application process is unfamiliar, the decision process is unfamiliar, so it's very hard to know exactly how to pitch one's proposals.
I think so with the large Recover initiative through the NIH, it seems to be a large pouring of resources into sort of an overall clinical cohort. For example, I think there are 3 components to that initiative, right? The clinical cohort, the EMR data, and then an autopsy component. And so I think it's in terms of thinking through funding and how to further advance the field, I think studies that are sort of falling under those umbrellas, proposals that are falling under those umbrellas are harder to pitch when there's already been such a large funding initiative put forward under the Recover umbrella. So things that I think about are, particularly interventional studies. I think that is certainly a big gap in conducting research right alongside clinical care. I think that's where the post-COVID programs can be particularly helpful, where we're meeting patients' needs while further advancing the field. Thinking about another aspect is taking a deep dive into certain areas, which is what we've tended to do on the cognitive front with Dr. Vanderjaal's work, and thinking about how we can look at more detailed data that perhaps might be available through some of the larger cohort studies. And then I think when we're thinking about big data sets, also thinking about how to sort of refine care and take advantage of some of the novel aspects of the pandemic. So certainly telemedicine, thinking about how we can further, I think, refine delivery, scheduling, sort of how we target which patients are scheduled off the bat for telemedicine versus in-person visits, thinking about how we identify those folks up front who might be at greater risk, thinking about the cost implications. But I think thinking carefully about how we can overall be competitive for proposals with this already invested NIH Recover sort of network.
Thank you very much for everyone's responses to that. If we could segue to the next question here, because I think we've really arrived there, which is that Dr. Uegman mentioned that there are some resources and scale at North Shore that have a lot to offer nationally in terms of what we could leverage. And so how do we leverage that and align with funding priorities going forward? And really to those, to Dr. Vanderstaal and Dr. Parker, having seen what's developing here, what are your thoughts? I should mention that North Shore is already part of the national COVID cohort collaborative with Dr. Solomonides' leadership, and so that's one example that I think Dr. Parker was alluding to. But are there others that you can think of that you might want to think about how we can really skate to where the puck's going to be with our work?
So I think thinking, again, I think considering sort of delivery of care, I think thinking through telemedicine, an opportunity to kind of look into how navigators might help to propel care and create more efficient pathways. I think those are sort of opportunities that are very, I think, timely, I think are important things that we need to consider moving forward, and is a way that the pandemic and COVID have really shaped how care will be delivered in the future, but a lot of refinement to be done. I know our sort of telemedicine pathways and delivery of care were turned on their heads, and we're still sort of recovering and thinking about how we're going to refine that moving forward.
So, I mean, it sort of rolls into point number 4, question number 4, thinking about how to create pathways and systems that are really focused on increasing access to patients who might not normally get into our system. As Anne said early on, a lot of the PACT patients, a fair number, we're really new to the medical system. And so we're identifying medical and cognitive and mental health issues that may be related to COVID, most certainly in some respects, but also maybe pre-existing and they really need services. And so setting up lines of care that involve bilingual providers, thinking about test batteries and sort of assessment tools that have demonstrated validity in multiple languages and cross-culturally. I think it's something that we're all realizing that we need to take better, more attention to, and I believe our funding sources are as well, wanting to make sure that when we are doing studies that we are being inclusive.
Thank you, and that's absolutely a really great point and a way to think about as these approaches are being developed in telemedicine and behavioral health, primary care at a system level, how we can take the opportunity to study that, its effects on equity and how to approach this in ways that engage with the community. So on that point, if we could move to the number 4, final discussion question. Many of you have raised this issue already, but how do we ensure that the research that we do in this area benefits everyone equitably? In addition to what Dr. Vanderstal said, some additional thoughts about how we can go in with a health equity lens in this approach.
So this is Bernadette Wigman. There was a chat question that Dr. Benson asked and whether we were evaluating our educational efforts. And it occurs to me that, there's a gap between the generation of knowledge and the use of knowledge, and that has to do with training and systems and that sort of thing. And so I think understanding how to educate and how to keep people up to date, broadly speaking, really in almost every specialty, is a pretty important objective in terms of ensuring that research benefits equitably reach everyone. Of course, there's the access to care issues and health inequities that are structural in nature that we all know about that are also incredibly important. And it seems to me with North Shore's emphasis on diversity, equity, and inclusion, that might be another avenue for us to explore that, really could be done in a meaningful way with a local population. Whereas I think, many of these cohort and clinical trial studies need to be multi-center, very standardized, that sort of thing. Whereas, learning about how do you train people to do this, and what are the most effective educational materials, and how do you reach people, for example, with telehealth who may not otherwise have access. You could evaluate those with much smaller sample sizes than are required for more rigorous, I don't know if I'd say more rigorous, but rigorous epidemiologic studies that do require significant numbers, control groups, that sort of thing.
I suppose independently of COVID, we at North Shore have been taking increasing care to record and understand social determinants of health. And I know we have a significant initiative in this respect. And just by the by, our local CTSA in which we're involved is making understanding what we describe as the sociome, the broadly conceived environmental, social, economic conditions, a major plank in its future, in its next phase.
So I'm just curious, this is Bernard again, to ask perhaps Tracy Ann and Tony, the large cohort studies, the recovery project, are those pretty much closed? In other words, they have everybody they need. There's no opportunity for us to contribute at this point. And the second part of that question is, what's the connection with N3C and the recovery cohort studies that have been funded?
My colleagues in N3C are asking the same question, I'm afraid. The N3C itself is underfunded, but an enormous amount of volunteer effort is going into keeping it going and succeeding. But I have to say there is some anxiety about the sustainability of this effort.
We've done some work with the N3C, specifically with Dr. Christopher Shute here at Hopkins, and have sort of lended our patient population to look at identifying patients with, that might fall under a PASC umbrella, but using the EMR data. As for the NIH Recover project, I don't have any particular insider knowledge. We did submit a proposal, but we weren't chosen as one of the clinical cohort sites. We are one of the sites for the autopsy arm of the studies, and I believe the EMR proposals are still under review. I think what I'm hearing from somewhat of a distance is, of course, this is a very, I think, different approach than the NIH has typically taken for funding. And so I believe there are challenges and some, rough spots to be ironed out. I don't know that the door is closed on potential funding opportunities. I think the first round of funding, at least for the clinical cohorts, has been allotted to some degree, but I don't know that that door is closed. I think that there's a large pot of funding that has gone to this initiative, and there may be several layers. But I wish I had more insider data, but I don't. Insider information, but I don't.
Likewise.
Thank you very much. So we have a comment from Sarah Polonsky. The MFMU team at North Shore will be starting. Do you know what the acronym means? MFMU team at North Shore will be starting a PASC study in the next couple of months, which will follow people who have been diagnosed with COVID during pregnancy, may have developed PASC along with follow-up on the children. Okay. So a maternal fetal medicine unit network. Okay. So there's work that's already being launched that is aligned with some of the equity issues that have been raised. There's also the issue of North Shore, because of expansion into Northwest Chicago, we have a more diverse catchment area, and the process of so doing involves some community engagement work, research, mixed methods, working with citizen scientists and community leaders. And that also seems to me an opportunity as preliminary data that could inform some comparative effectiveness work that's patient-centered on how we democratize testing and treatment and vaccinations and follow-up, and also identify very high-risk patients early. So there's just some thoughts that came up there that we might explore. What I don't know about is what RFAs and program announcements are coming down the pike, or is everything already wired? And that I'm not sure about. Are there any other thoughts about the equity issue? I think I'm sure there's a lot more to say about this. Clearly, there's disparities in the severity of the post-acute sequelae of COVID based on the work that I've seen here. And in primary care, thoughts about how we might be better able to be preemptive would be interesting if you have any thoughts.
I think just I don't have any fantastic, groundbreaking thoughts, but I think just first step is recognizing the problem, right? I think we've all certainly seen that we are seeing a disproportionate number of minority patients who are presenting very severely, acutely ill with COVID-19. And so I think that's problem number one. We're seeing that, of course, there are issues around access to care. And I think carefully sort of thinking through how we can better understand that at various levels, you know, access to technology. Once technology is accessed, how we can leverage things like telemedicine visits to meet patients kind of where they are. You know, helping to use algorithms to identify which patients are more likely or more capable of showing to appointments via telemedicine or in person, for example. You know, engaging our interpreters and making sure that we're having access to interpreter services for telemedicine visits, for in-person visits as well. And as we conduct research, it is just super important. I think anecdotally, and I think this is borne out in you know, some of the recent studies that we're starting to see, including a recent JAMA paper, sort of understanding that our patients who you know, may be typically underserved, for example, they might be in frontline jobs. Certainly that's a risk factor for exposure and development of illness and then, you know, subsequent severe illness. But we're also seeing when they're presenting to our clinic, they might not be able to take off time from work to actually get to an in-person visit. And so maybe, you know, perhaps these patients might have better access if they can get on their phone from work and join a telemedicine visit to start, and then have more directed follow-up thereafter to make more efficient use of the time that they do have, you know, away from jobs and things like that. And so, you know, there's just a lot more work to be done in that area, but this is a great opportunity to do so if we're going to make lemonade out of lemons.
Thank you very much. Very well said. And we're at the time of the seminar where I'd like to again thank all of the speakers for a really impressive, stimulating set of presentations. And just a few thoughts. I mean, clearly, the magnitude of this problem is huge and is going to be around for several years. And there are a number of knowledge gaps that the scientific and clinical community didn't have the luxury of having been worked out for decades before. And so there are many that remain, but it seems that there are quite a few opportunities to address what we've learned from these systems that have been stood up with really great success in terms of implementation, but also on how to address the issues around equity with the care we provide. And I do think it seems that there are many possibilities to align with NIH funding priorities, but also to promote the population health outcomes that we really hope to achieve from this. So I'd like to again just thank everybody. If there's any last thoughts from anyone, please feel free. Otherwise, I would like to summarize the next steps here. Can we go to the next slide? So Francesca has entered information about how to a link to the evaluation following the survey in the chat. And we'll also email that to all the participants after sometime tomorrow with a link to the YouTube channel. But for any questions about today's seminar, ideas for future seminars, please contact me directly. My email is on the slide here. And please do take the time to evaluate the seminar today. We do read the evaluations and they're very helpful for us in making sure that this is maximally useful to everyone and people feel included in the process. And again, there will be a recording of this on the North Shore YouTube channel. That should be available shortly, and you might want to check in sometime tomorrow, next couple of days to post that. Also, please stay tuned for our 2022 winter schedule, which is yet to be announced, but I will be sending out information about that in the next few weeks. And again, thank you, everyone. I will virtual round of applause. And I apologize for the technical aspect of I think there's an unstable internet connection. So the video may be a little frozen, but certainly heard your voices loudly and clearly and appreciate all the heroic work that you've all done. So thank you all very much.
Thank you. Thank you, Sean. Well done.
Thank you.
Thank you for having us. Great conversation.
Thank you very much.
Yeah,
It's
appreciate you joining us. Really very, very helpful insights.
Thank you.